Good morning, everybody. It's fantastic to see the turnout this morning. For this morning's talk, I mean, this is so exciting that we're able to meet and we're able to talk about these things. And 10 years ago, to be honest, if we were talking about the science of dementia, progress and possibility, well, we probably had way more possibility than we had progress. And it's fantastic to be here. I'm working in memory services now for over 20 years. And to be able to talk about realised potential as well as the future potential. And that's what I'm going to touch a bit on. There is no question too silly. So please, part of this is, at the end of this, I'm happy to go through anything that might go through in the slides, that was a little bit confusing or wasn't clear enough. So we'll have time at the end of this to kind of talk through different aspects. And there's loads of things that I haven't been able to get into the weeds on or into the detail on. And there's loads of nuances. You can imagine that something that's moving as fast as this area, there's loads of different nuances, and people will have read about different aspects of things. So if you want to get clarification on some of those aspects, also really, really happy to do. It's phenomenal as well, the collaboration that we have between the clinical and the clinician world, the advocacy group, the people who are living with the condition, and then the advocacy organisations, and then the scientific community as well who are pushing on. And I think that's, we take it for granted in Ireland that all of this seems to happen so easily, but actually I know from talking to international colleagues, it's not every place that have this seamless interaction and integration between all of those things. So a huge thanks to the Alzheimer Society of Ireland for pulling all of this together. A few of these seem to have jumped around. Anyway, I'm going to start by, when we talk about brain health, if I had brought up the idea or started talking about potential for lifestyle modification as a means of reducing our risk of developing dementia a few years ago, really it would have been laughed out of the room. It wasn't seen as something with credibility. So one of the big advances that we have over the last decade in particular has been this recognition that the scientific evidence really strongly supports that there are certain risk factors that if we address them, we can reduce our risk of developing dementia significantly. But the words brain health, they really go to far more than just talking about that. They talk about sensory issues, they talk about social and emotional issues, behavioural issues. So rather than, and it's something that happens right over our life course. So from before we're born, to the day we die. So there's a whole life course relationship with it, and at different parts of that life course, different risk factors are more prominent, and it's irrespective of the presence or absence of disorders. And this is the WHO, the World Health Organization classification. So it's not just about preventing or delaying dementia. It takes in far more dimensions when we chat about it. And when we think about what we call cognition, and cognition is, I suppose, many of our thinking aspects, so our planning, as well as our memory, as well as visual and spatial abilities, as well as auditory and comprehension abilities. So cognition is more than just being able to remember stuff. And when we look at our cognitive performance as we age, well, it changes. So our lifetime risk of remaining as good as our peak to the day we die is around about, or should I say our lifetime potential of remaining as good as we were at our peak cognitive performance until the day we die is around 5 to 10% of lucky people. Okay, so it is rare. So a change in our cognitive performance as we age is the rule, not the exception. Our lifetime risk of maybe developing dementia is around about 25%. Okay, so the vast majority of people will live and won't develop dementia, but 25% is a big number. About another 30 to 40% of people will have a thing called mild cognitive impairment, and I'll go through what these different terms mean, because I think that's really important. Mild cognitive impairment is where people may have memory issues or may have other cognitive issues, but get about their day-to-day activities. So those are kind of the different, if you like, experiences that people can have, and it's just to set the scene around what it is that we're sometimes fearful of, or to put in context, how it is we're at. And as a geriatrician, and I trained as a geriatrician, even though I work in a memory service now that looks after people of all ages, is that we're born as copies and we die as originals. I mean, that's our creed. And the reason why that is that we have these set milestones up until the age of 3 and 4 years of age that we can anticipate what most babies and then children should be doing. But if we look at the other end of the life spectrum, we've had all of that lived experience, we've all of those experiences that people have had through life, we've had all the good and all the bad. And as a result, there is this kind of much greater complexity and richness at that stage of life. But also biologically, you've had previous infections, you can have neurodegenerative conditions, these conditions that affect the brain, like the conditions associated with dementia, but also Parkinson's disease and other conditions. You can have had significant infections or medical illnesses, you can have had strokes, you can have had cancer, so you can have had other biological events that have happened, and you could have a biological resilience, a resistance to those events that really colours how you're at, when it comes down to how your brain state or what your overall brain health is at around the age of 70 or 75 years of age. So you can see why us as geriatricians, we really, we're generally a group of clinicians and practitioners that enjoy that diversity, that we see at that stage. And some of this, when we're looking at the age of 70 and we're kind of trying to anticipate risk, comes from this thing that we call cognitive reserve and resilience. So where did the whole idea or concept of brain health first come from? It came from the fact that we identified that when we looked at people who had passed away at the age of 90, and we looked at their brains, we identified that about 40% of them had sufficient changes in their brain, in particular changes we'd see with Alzheimer's disease, that really they should have had dementia. When we looked at other people who had developed dementia, they would have had similar amounts of pathology, and yet this group of individuals didn't develop dementia. So they had this resistance, they had this resilience to developing cognitive symptoms. And when we looked back through their life then to study, okay, well, what were the things that they had in common versus the people who developed dementia? Well, we found things like education, we found things like occupation, and then as we looked more and more, we'd see some of those other risk factors that we thought. So we actually identified, this whole concept of brain health and the fact that there were things that we can do from this proportion of people who are resilient to the effects of that pathology. And that means that we know that there are certain activities we do, in particular around midlife, that if we address, give us a resilience. But actually we see it all the way through into later life. That give us a resilience to, even if we develop pathology. So these things will reduce the risk of us getting these changes in our brain, but also give us a resistance to those changes in our brain, should they happen. So then to kind of just to loop out, okay, so we talked a bit about brain health. Well, what is dementia? And I'm sure most people, and there's loads of experts and people with lived experience in this room to know, the answer to this, and that oftentimes it's given as a diagnosis, and dementia isn't a diagnosis. It's a term that we use that describes where, as a result of a memory or thinking problem, somebody is not able to do their day-to-day activities as well as they did them before. That can be very, very subtle. It can be more significant. It can be different if you're still working to if you're retired. So it is open to interpretation, but the key part is that you and the people who know you well feel that there is a functional effect of these kind of cognitive changes. And it's an umbrella term. And by that, it's a term that kind of, it describes a syndrome rather than actually being something specific. So, in the clinic that I work in, we would rarely use dementia unless we had gone and we had excluded other reasons and couldn't find, dementia wouldn't be where we would stop at trying to give somebody clarity around what's causing their symptoms. We know that there's around 65,000 people who are living with dementia in Ireland at the moment, about 1 in 13 people at the age of 65. And we know that age is the biggest risk factor for developing dementia. And the reason why, and I'll touch on it a little bit, is as we grow older, the brain is just less efficient at clearing these proteins, and these proteins that cause it accumulate in the brain. So that's why age is that significant risk factor. And that means that with the very big success that we have of the population aging and people living longer, even though we're gone better at kind of identifying and managing it, there will be more people who will be living with dementia. But there is some positive notes on that. I mentioned the other thing, mild cognitive impairment. And mild cognitive impairment is increasingly important. It was first coined as a phrase, really just around 2000, 2001. Okay, so it's a very recent term that we use within the context of diagnosis. But mild cognitive impairment is where you have objective evidence that somebody has a memory or thinking problem. When we do our testing, they subjectively feel their memory, or their family or somebody else feels that their memory isn't as good as it used to be. But for all purposes, they're doing their day-to-day function. And I suppose the reason why it's become important is it's become that at-risk zone for dementia. And there are different ways that we can classify it as to whether or not it's memory predominant, or whether it's other cognitive domains. So it could be visual, or visual spatial issues, could be language issues. So not everybody with mild cognitive impairment would go on to develop dementia. There is a reversibility to it, where some people with mild cognitive impairment will get back on track and be on their normal trajectory, or the regular trajectory that they would have had. So it's a dynamic state, and that's why it's really important, because brain health, in particular in this group, might be very, very important. But they outnumber people who are living with dementia by about 3 to 1. So it's about 150,000 people in Ireland who are living with mild cognitive impairment. And if we extrapolate it forward, there'll be almost 500,000 people over the next 2 decades who will be living with mild cognitive impairment. And those are the people that, probably some of these new tests that I'll talk about, the diagnostic tests, and the therapies will be very relevant to. So it's the ground is shifting. So before 10 years ago, in particular, our only stage at which we diagnosed Alzheimer's disease was at that dementia stage, where people had clear functional loss. Whereas now, I'd say we're at least as many times almost diagnosing it at the mild cognitive impairment stage, that earlier stage before functional loss. And I think it's I just highlight this from the point of view, it's sometimes hard to imagine what we mean by we're all growing older. This is a headline from 2021, where babies born in Ireland today will have an average life expectancy of 105 years. Okay, so we've made extraordinary gains from the point of view of the length of time that we're living. And that's what we call lifespan. But actually, as a geriatrician and as clinicians now, we've become obsessed with a thing called our health span. And our health span is the amount of years we live healthy of that extended lifespan. So we've had the success of living longer. Now it's around how do we make sure we live healthier. And when we look at multiple populations around the world, whether you're in a developed country or a developing country, there is this gap between lifespan and health span. And in developing countries, it can often be bigger or smaller depending on the lifespan. In developed countries, it's bigger or smaller depending on how well we manage chronic illness or chronic conditions. And in most developed countries, dementia is the condition that overwhelmingly accounts for this health span gap. And this is across the population, and it's estimated to be around 9 years. So about 9 years towards the end of your life, whereby your health isn't as good as it was previously, but you're probably going to go. And that's what we need to really work on, that gap. And as geriatricians, and this is from my colleague in Tallaght, Des O'Neill, where he coined geriatricians as guardians of the longevity dividend. And it's just where we really kind of get in and try and make sure that we work on that. And I think, looking at the condition that is dementia in its whole, as that umbrella term, is a really good thing, because it is this common thread between lots of the other things that affect us as we grow older, such as things like incontinence, frailty, where our muscles get a little bit weaker, falls, which are twice as common and more likely to be injurious if somebody has a memory issue, but also you're more likely to develop dementia if you have falls. So often falls can be something that precedes our risk of developing dementia. A thing called delirium, which is an acute confusion that can happen when we go into hospital, if we've done the wrong medicine or if we have a kidney infection, and all of these service pressures that we see on the ED and block beds and things like that. So dementia is this common thread, and it's bi-directional. So you're more likely to develop dementia if you have one of these conditions as you grow older, but you're also more likely to develop dementia if you don't already have it, if you get one of these conditions. And I think it's also really, really important because when somebody receives a diagnosis of dementia, it frames their eligibility for other care that we might do. So sometimes, we think around, okay, those relationships with regards where somebody living with dementia might get these other conditions that might adversely affect their health. But also, we sometimes don't think of the care that people don't get because they have what we call this diagnostic overshadowing of a diagnosis of dementia. So in other words, they don't get the cancer treatment that they otherwise would have gotten, or they don't get the surgery that would have alleviated their pain, or their symptoms that they otherwise would have gotten, or even something as straightforward as dialysis. And the most common reason for discontinuation of dialysis is cognitive symptoms. So there are other aspects that then feed into the wellness that somebody who's living with dementia can have as a result of the diagnosis. So interacting or impacting on the amount of people who are living with dementia by addressing these brain health risk factors, by supporting people to live better with dementia, will have a seismic, it's the biggest probably impact we can have or hope for in all kind of clinical spheres at this stage. We have addressed so many of the infectious disease causes. We've got so much better at cancer. We've got so much better cardiovascular, strokes and heart attacks. Probably the last real big thing for us to try and, the last big challenge for us to address in a substantive fashion is this. The most common question I get asked in clinic is, what's the difference between Alzheimer's disease and dementia? And it's because in society we kind of tend to interchange the two terms. And as people know here, Alzheimer's disease, unlike dementia, is a specific diagnosis, as is vascular dementia, which can be caused by strokes or Parkinson's-related dementias, like Lewy body or Parkinson's disease dementia, which is caused by other proteins, or frontotemporal dementia. So there are lots of different causes of dementia, and the key thing is that we work through to get the specific cause of dementia or their symptoms for somebody so that we can help them understand why their symptoms are as they are. The big advance we've had in the last 25 years has been a clarity of understanding. Now, we knew actually over 100 years ago in some of these cases. Aldous Alzheimer's described Alzheimer's disease pretty perfectly in 1906. But it's really in the last 25 years that we've understood the relationship between these toxic proteins that build up in the brain that cause these dementias. So it's amyloid in particular for Alzheimer's disease, it's alpha-synuclein for Lewy body, it's tau and TDP43, different proteins for frontotemporal dementia. So different proteins building up in different parts of the brain cause different symptoms. And I suppose why Alzheimer's disease gets used more commonly than the others is because it is the most common cause. It's the primary cause of somebody's dementia in about 70% of cases over the age of 65. And it's probably about 50% of cases under the age of 65, where there are other conditions are more common. But the key thing is by understanding these proteins, by understanding how they affect the brain, it's helped us to develop these medicines, to push on and to target those proteins and to see if we can eliminate them. And the key thing is that if you take Alzheimer's disease, we've got MRI scans now that we can look at. We've got things like a lumbar puncture, which we've been doing for over a decade, where we can measure the levels of these proteins. They're pretty invasive. We have expensive imaging, a PET scan, which isn't a scan on your dog or your cat, but it is a special, sophisticated CT brain scan where we give a radioactive dye, and we're able to stick that dye to the protein amyloid or the protein tau that builds up in the brain, and then by that we're able to quantify the amount of it in the brain. But most excitingly, we're probably right on the cusp in the next 12 months certainly of having blood tests, and all the research has kind of evolved at this stage to validate where we have a blood test that's able to do these things. And probably one of the key messages is these biomarkers, markers of the biological condition, are positive up to 15 years before people have symptoms. So it gives us this big window of opportunity to try and get in and identify those groups who are at highest risk and kind of be able to instill a brain health platform or potentially therapies or other strategies to kind of reduce their risk significantly. So that's why there is so much talk, that's why there is so much excitement around these biomarkers, because if you can imagine, and sometimes it's very reductive to try and compare, let's say, what the terminology that we use in cancer to the terminology that we use for a complex condition like dementia. But if you can imagine just identifying, the risk of a tumour at much, much earlier stages, well, everybody understands that that's what we're looking to do, and that we have more therapy opportunities if we identify at that stage than we do if something has become more progressed. And it's the same for dementia. And as a result now, as opposed to 10, 15 years ago, when we were only diagnosing Alzheimer's disease at the stage whereby people have functional loss, we're now diagnosing it at a stage whereby people have mild symptoms, so that mild cognitive. So, if you like, there's this continuum now. And over the next few years, actually, it'll probably become even more routine to be diagnosing Alzheimer's disease before people have symptoms, asymptomatic Alzheimer's disease. And it's that, I suppose, we as clinicians, and I think society at large, are kind of trying to get our heads around, well, what does that mean, and how do we even assimilate that kind of reality, and how do we direct resources, and how do we support care for people who have this wide spectrum of symptoms, from people with advanced symptoms as a result of the same condition that people may have no symptoms of. But it's a really exciting challenge. And I think most people would rather identify and know their risk early on so that we can modify it. The Lancet Commission reports, and this is the highest order of evidence that we can come up with that's published, every year. So the first Lancet Commission report looking at risk factors for dementia and its potential reversibility was published in 2017. So that's how new this whole concept of brain health is. And there's been subsequent, because of the overwhelming amount of research and evidence that's coming through, they updated in 2020 and in 2024. And the key thing that you can see, we've gone from 9 risk factors that we know are clearly modifiable to 12 risk factors to 14 risk factors in 2024. And I think the other thing that's really noticeable is how midlife risk factors have really grown out. And by midlife, we're really talking up until 65, 70. That's what we're talking about in that midlife zone. And what they've kind of is there's opportunity to modify these risk factors at all stages of life, but in particular trying to focus in that midlife zone between 40, 65, 70 is a real crucial opportunity. By addressing these risk factors, these modifiable risk factors, 45% of cases of dementia are potentially preventable. That's a huge, huge number of cases. By doing these things that are also really good ideas from the point of view of reducing our risk for cancer, stroke, heart disease, and other ailments that affect us as we age. And it does require policy changes. It does require a policy focus from government. It requires then also individually tailored kind of programs to be able to support people to do these things. So many people will have heard of the Irish Longitudinal Study of Aging. We're really lucky to have this vibrant longitudinal study of individuals who've aged. And we looked at brain health and brain health risk factors in this population. And Caoimhe McGarvey led out in this research. And it was only published in the last few months, but it was really, really startling. So the TILDA, the Longitudinal Study of Aging, is people aged 50 who are cognitively intact at baseline. There's, just under, give or take, between 8,000 and 10,000 participants who are in it, and the people who've been followed up over, a long period of time. And we looked at the 10 years of follow-up, and we looked at the risk factors and modifiable risk factors. So we took this Lancet report and we said, okay, well, in the Irish population of people who are aged 50, who are living in the community, who have no cognitive issues at baseline. So they're all people who, when they entered TILDA, had no cognitive issues. How many risk factors? How many modifiable risk factors? What's our opportunity here? And what we found was 70% of people had at least 4 of these modifiable risk factors. Okay, so then we also went and looked and we said, well, what were they? And the key ones, hearing loss, the cardiovascular risk factors such as smoking, high blood pressure, obesity, and visual loss were the ones that were recurrent. And we found that over 3/4 of people who had severe cognitive decline over the 10-year follow-up had at least 4 or more of these risk factors. So it mapped. What the international research was telling us, that connection between risk factors and people's risk of developing decline, was real. We also looked to see were these risk factors addressed, and unfortunately they weren't. And potentially, if we extrapolated out to the Irish population, so about 500,000 people aged 50 or older are probably living with at least 4 or more brain health risk factors, and over the 10 years we missed the opportunity potentially to prevent 32,480 cases of severe cognitive decline by not addressing these risk factors. What are the things that we can do? Well, if we go back to those 14 risk factors, the things that we could do to actually address the lion's share of them is the education. Okay? And actually that's mostly being addressed now. So in the Tilda cohort, only 50% had completed second level education. It would have been around the 50s or 60s. Whereas now most 90% plus, nearly 95% of people complete second level education. So that's one risk factor that's already addressed. Sensory aids, hearing and vision, getting them checked. Nobody can tell how good or bad their hearing or their vision is. Your brain will always lie to you. It will always tell you it's fine. Listen to your wife, your husband, or the other person who's living with you who says it's not as good as it used to be. We just can't. It's one of the fundamentals. Our brain has these feedback mechanisms to reassure us, okay, everything is grand, no problem. I don't know what they're talking about. All right, so sensory, get your eyesight and your hearing checked, and it makes a big impact on lots of different aspects as we get older. I highlight XWell, but these community exercise programs, or the access to XWell, CL Blue, or these other, where you have this communal exercise, are really, really important from the point of view of looking at physical activity, but also social interaction, social engagement. And we're really looking at the Tallaght area, but lots of areas now around the country have, there's this growing kind of, pop-up and growth of these community exercise programs, but they're really, really important. And people often need help to get started. And these groups are really good at helping us get started. And then cardiovascular management. So knowing our numbers, knowing our blood pressure, knowing our cholesterol, knowing our blood sugars for diabetes are really, really important. And this is not complicated stuff to manage, okay? And all of those together gets us to about a 35-36% risk reduction of preventing dementia. So even if we don't take the whole meal, and some of it could be complicated, we can, if we did these things, we can make a big dent. There's other modifiable, and the good news is we have even more potential than has been highlighted in the Lancet Commission. And I don't have time to even go through all of these, but sleep, circadian rhythm, we know is a very big risk factor and important. Menopause, and addressing symptoms around menopause is a really important risk factor that's modifiable. Diet and Mediterranean diet as a positive versus a negative diet is a modifiable risk factor. Poverty, income, and inequality consistently comes true for dementia, cancer, and these, and for these conditions. Atrial fibrillation and irregular heart rate, yet again, is a modifiable risk factor for developing dementia. So over the years, as we accumulate more evidence, I think we're going to see even more of these modifiable risk factors and even greater impact potentially on developing these conditions. I do want to highlight one though, because it's very, very important, and it is, if you like, it's that low-hanging fruit that we're really not getting the message out about enough. Vaccination is a really potent risk reduction strategy for developing cognitive impairment and dementia in later life. Influenza vaccination. We know one flu vaccination is associated with a 17% reduction in Alzheimer's disease in later life. Cumulative, so over a number of years, if you have, over 4 years you're getting your flu vaccine every year, it equates to almost a 60% risk reduction in developing dementia. Okay? It also reduces significantly your risk for stroke and heart. So while we talk about the flu as kind of this nuisance thing, and some people may go, okay, well, I'll definitely feel a bit woozy for 24 hours if I get the jab, whereas I'll take my chances on not feeling, that I won't get the flu. But actually, there is these effects that happen, and we saw it in COVID. Okay, so the non-respiratory effects of these viral infections is very, very impactful on the brain. And we're beginning to understand this even more, and probably no more so than with the shingles and the shingles vaccine, where now there have been around 6 publications, I've highlighted one here, It's found about 6 publications, all very, very consistent over the last number of years, that have identified this significant risk reduction with having the shingles vaccine and developing subsequent cognitive impairment or dementia. And there hasn't really been a study to counter any of these. And that's, as clinicians and scientists, that's often what we're looking for. We're looking for, one observation, because these aren't randomized controlled trials. They're not trials whereby we give one group a dummy drug and the other group the vaccine. They're observational studies, so we're looking at populations. And there's been some, like this study that I've highlighted here in Wales, there's been some natural, if you like, studies whereby a government has funded the vaccine. So we got a big group who never had it and a big group who then received it. And in this was probably with the older vaccine, we could see a 20% reduction. With the new vaccine, which is available, it's an almost 40% reduction in the risk of developing dementia. And shingles is an awful condition, and people may have heard me talk about this. It should be reimbursed in Ireland, because as it stands, people have to spend over €500 to get this. And I think it's one of our glaring on goals within our public health service, that this isn't reimbursed. So our understanding of brain health is occurring across these extraordinary advances in how we diagnose it and how we treat it. But the good news is an 80-year-old today is 40% less likely to develop dementia than an 80-year-old 40 years ago. And we know that from this study called the Framingham cohort study in the US, but also from loads of similar studies in the UK, Netherlands, Spain, and Sweden. Okay, so our age-adjusted risk of developing dementia is much lower. We just have way more people who are aged 80 living, and that's why we're seeing those bigger numbers. And that's because the first disease-modifying therapies really work on blood pressure medicines, cholesterol agents, diabetes medicines, and these even more recent anticoagulants that we see for atrial fibrillation. So they were the first generation of, if you like, our disease modifiers. I've mentioned around the blood tests that are coming. The blood test is this test called p-tau217. We know from multiple studies now at this stage, in clinics and in research groups, that the result in this blood test really matches up to what I do as a lumbar puncture, which is a needle into the lower back, or the amyloid PET scan, that fancy scan that sticks to the proteins and I understand. So a simple blood test will be able to give the same diagnostic accuracy as those more expensive and more invasive tests. So that will democratize our ability to make a more accurate diagnosis. And you might say, well, weren't people always getting a diagnosis before we had these tests? Well, there is multiple studies that show in a third of cases, without knowing these test results, we get it wrong. We call something Alzheimer's disease that isn't, or we call something else that is Alzheimer's disease. Okay? And in medicine, an error rate of a third is huge. Okay? So these will transform that accuracy, and they will also drive standards from the point of view of new therapies and helping people understand their symptoms. And I think they'll be available in memory services, or through memory services, over the next 12 months or so. There's a load of talk, and I got this slide off Laura, there's a load of talk about these new therapies now, and these new medicines, and where do we stand on it? Well, right now in Ireland, nobody in Ireland is receiving those therapies in Ireland. There are some people from Ireland who are travelling other places to receive these new treatments, and I'll talk a little bit about them. But also from Laura, it's kind of, how do we kind of assess this information? Because there's lots of stuff in the media about it, and there's lots of stuff in the media all the time about new treatments for dementia. From salads, to oily fish, to weight loss, to chocolate, to coffee. Recently there was loads of stuff about coffee consumption reducing our risk of dementia. And really, whenever we're looking at these things, and even this from myself as a practitioner, when I'm looking at journals, but in particular if we're looking at it in the media, it's who's reporting it, are there credible experts kind of quoted with it? Looking at the headlines, whenever there's something put out in the press, actually, the people who actually might have contributed to the book don't get to contribute to the headline. So there's separate people employed to write the headlines. So oftentimes the headline is a bit sensationalized to hook you in and may not reflect the body of the text. So it's important to read the text underneath. And then looking at the evidence, like how many people was this involved in? Okay, was it a trial or was it an observational thing? So was it something that we just looked at people and we said, oh yeah, there's that relationship? Because observation doesn't give causality. Okay? Only a trial can try and establish causality. And then was it on animals or humans? And disease modifying, when we talk about disease modifying, our current medicines kind of are symptomatic medicines, and they intervene at the latter stages. So there's this thing called the amyloid cascade hypothesis, which describes where amyloid in Alzheimer's disease builds up in the brain 10 to 15 years before anybody has symptoms, and it causes this cascade of events, including inflammation in the brain and the development of this other protein tau, the accumulation of this other protein tau. And ultimately that damages the brain cells, and this cascade happens and evolves, particularly over about 10 years before you kind of are getting to mild symptoms and then progressing on. These medicines intervene much, much earlier on. And the main ones are called lecanemab and donanemab, and I'm not going to get into, just in the interest of time, I'm not going to get into huge amounts of detail on them, other than they've come through 2 pivotal trials which established that they were effective at reducing the risk of people having progression in their memory symptoms. Probably not as effective as we would aspire to for medicines, but a big step forward. They removed the culprit protein from the brain, and the removal of that protein from the brain was associated with an improvement in memory symptoms over 18 months, give or take, in both cases. One is a fortnightly infusion, the other one is a monthly infusion, and there are risks of little bleeds or little swellings in the brain associated with both of these treatments. What has been quite reassuring has been the open label extension. So when we've looked at these people who received these medicines in those trials, and we look at them 3 and 4 years on, they seem to have a legacy benefit of having received these treatments compared to what we would have expected to have happened. And that supports the notion that these could be disease modifying, as in they're not just symptomatically helping, but as a result of targeting this protein amyloid and removing it from the brain, they are associated with a positive effect. Right now in Ireland, the HSE and the NCPE are making a judgment with regards to financials for these medicines around their availability and when they will be available in the public service. I would expect it may be at least a year to 2 years before, even with a positive verdict, these medicines will be available in the public health service. But, I think the other thing that's important about these medicines, and we've looked at it in our memory service and other memory services have looked at, right now, because biomarkers aren't as widely available as we want, because people probably present a little bit later with their symptoms than we want, because of the complexities of services, probably less than 10%, less than 1 in 10 people who come through my memory service would be eligible for these medicines. So it's a small proportion of people, and even a small proportion of people with Alzheimer's disease, by virtue of other medical illnesses or other medicines that they're on or other reasons, who would be eligible for these medicines. Okay? So it's actually, it's not something that, these medicines aren't as effective as we want them to be in the future. They're not as safe as we want them to be in the future, but they are a major step forward in treating a condition for which we had no other treatments. And I think that's where there's this mixture of enthusiasm but caution. And I think that comes across in some of the media as well. And the key thing is this is a slide that just shows the pipeline. So there's 182 trials, 138 new therapies for Alzheimer's disease coming through, 31 treatments in phase 3. That's late stage trials. So there is this whole new era of medicines coming through to treat Alzheimer's disease. So the take-homes. Brain health is a modifiable lifespan concept. So, it's much broader than just preventing dementia. It takes in loads of different aspects of how we live, and it's all the way through our life. From early stages right through to things that we can do in later stages, such as social connectivity, cognitive stimulation, and all of those other activities at that stage. Nearly half of dementia risk is at least delayable, if not preventable, and that would make a big impact. How we diagnose it and how we treat Alzheimer's disease is rapidly evolving, and in a year's time I could be given a different talk again. And it's phenomenal to be working in an era where that's possible, because for 20 years we really didn't have a huge amount that we could talk about in that regard. Vaccination is brain protection, and I can't, yet again, there's loads of good reasons why people should get their flu vaccine, and where they can afford it, the shingles vaccine as well. And really, we need to get better at embedding brain health into our clinical practices to make it easier, make it more accessible, to have more experts, to have more easy access to cognitive stimulation and other and other programs that can help with those things. So thanks so much for the opportunity and to chat this morning.
Thank you so much, Professor Kennelly. You gave Professor Kennelly a really hard job in basically setting out the whole lay of the land. So I think that was impressive in such a short space of time. Does anyone have any questions? Oh, okay, lots of questions. Now, we might only be able to get to one or two. I see this lady here. Just get you a mic.
You've already had shingles. Is it worth getting the shingles vaccine?
Yeah, so people with shingles are probably already recommended to get the shingles vaccine too, because shingles it's the same similar virus as causes cold sores, and don't you know how you get recurrence? So it lays dormant, it goes back into the nerve root, it comes back out. So yeah, so vaccine actually, for somebody who has shingles, there's probably even an added bonus in that it reduces shingles is such an awful rash when it has so many symptoms itself that would be great to be able to prevent. But yes.
We have a gentleman here in the second row, Larry.
Could I ask you what are the impacts of stress and anxiety that is very much part of our society now?
So just, Larry has asked, what are the impacts of stress and anxiety that are very much part of our lives now?
Yeah, so I know that Professor Roach is going to talk a little bit later on about some of the psychological impacts. Our brains, I suppose, evolved from an era when stress was when a saber-toothed tiger jumped down in front of us. Alright? And it's now struggling to manage in this modern era whereby we have stress provocation and it's not a saber-toothed tiger. And we have these fight or flight chemicals that get released in that context. In particular, this chemical called cortisol. And when it happens, the idea or the mechanism, and I'm going out of my depth, and I'll defer to Professor Roach later on, but the mechanism was that we didn't dwell and look into the eyes of the saber-toothed tiger and sort of say, God, they're lovely eyes, and I wonder is that the same one I saw earlier on. And what was I doing earlier on? You turn and you bolt. And you can imagine when that's being released in the context of somebody who might be living with mild memory difficulties or might be at risk of delivering, it ratchets up a change in the brain. It also ratchets up changes in the chemical composition in the brain. And we know that there is a relationship. And there is some really interesting research. Actually, Gio and I, we had a presentation a while back where we looked at lifetime stress. So it's not just in the moment or in the acute for somebody who's living with a memory difficulty. There is also lifetime stress events. So when we looked at a cohort of people who had lived through the Troubles, there was an increased risk of developing dementia. We know that survivors of child sex abuse have an increased risk, and we know that where there has been other traumatic events early in life, there is increased risk. So we don't fully understand the causality. Because remember, I was saying there's things we observe, and we can see patterns in, but we don't understand necessarily the exact causality. But we see enough relationships to say that, it's a good observation that we do see this connection between higher stress levels and sometimes a change in cognitive performance.